Hello, everyone, and welcome to this Lunch and Learn webinar. We're just going to wait for a minute or so while people join us. But hello, and thank you for attending this session. We are going to be talking about diabetes, structured education, facilitating access for adults with type 1 and type 2 diabetes. So just exploring what is available for adults living with type 1 and type 2 diabetes in regards to structured education. This is the second webinar. We had a previous one in early November, and so this is a repeat of that webinar. At the end of the webinar, we will be sharing resources, and we will also give you the opportunity to ask questions. So there's a chat function available. Please have a chat with each other on the chat. But if you want a question to be answered, please put it in the Q&A. We will be going through those at the end of the session. A copy of the presentation will also be emailed to you, as well as an implementation pack with a lot of the forms and flyers that we'll talk about during this session. So just to recap, Q&A is for your questions, chat is just to chat amongst yourselves, and a copy of the presentation and the implementation pack will be given to you. Right, so let's dive in. My name is Candice Ward. I am the CDEP lead. I'm a diabetes educator by background, and I am your host or chair for today. So thank you again for attending. I'm also now going to hand over to Helen Slee. She is going to take you through the content and is our key that we can ask all those questions to. So I'll hand over to you, Helen. Thank you for joining us today.
Thanks so much for inviting me to spend the time talking to you today. So I'm Helen. I'm a programme manager working at NHS England. I'm going to be spending the next 30 minutes or so talking about structured education and the national offers that are available. So we will be running through this presentation, and like Candice said, we'll have some time to answer some questions at the end. So with that, I will just get started. Bear with me, there we go. So by the end of the time that we have together, I'm hoping that I will have been able to impart some information to you around increasing your understanding of the benefits of structured education, increasing your awareness of the offers that are available from the national team, and also increasing the understanding of the referral routes that are into the different services, including how to implement each of them and the resources that are available. With that information, hopefully it will help you understand which service is best for your patients and enable you to identify eligible people to refer into the programme. So just a bit of background on why we've delivered this session and why we're doing this national rollout of digital services is that the long-term plan committed to expanding further provision of structured education, and in particular digital self-management support tools. The reason for this was because through the National Diabetes Audit, it was identified that although offering structured education was recorded as quite high, the rates of attendance of structured education was very low. So it suggested that there were some barriers to attendance between that offer and actually taking up the course. So we did decide to offer some nationally commissioned digital structured education programs to reduce variation across England in access to online support, provide some patients choice, and also to increase the attendance of structured education more broadly. So that gives you a little bit of context around sort of the reason for why we have focused on digital self-management tools. More around the subject of why diabetes needing structured education. Well, as you will know, diabetes is a progressive long-term condition that is largely self-managed. Research has suggested that people living with diabetes spend approximately only 3 hours a year with a healthcare professional. So as a result, the majority of their time is spent managing the condition on their own. There's also been research that suggests that non-attendance at education has been linked to a fourfold increase in the risk of developing complications. So structured education has a really important place there in providing knowledge, skills and confidence to be able to successfully self-manage diabetes. It has been proven to help reduce diabetes-related distress, improve health and well-being, increase confidence in making decisions about your healthcare and treatment options, and also provides practical information, things like maintaining a healthy weight, diet and exercise. NICE also recommends that structured education should be offered throughout the diabetes pathway from both diagnosis and at annual review. So there should be opportunities taken at every point where there is contact with a patient to offer education where it's felt that self-management could be supported through a course or education. And apologies, throughout this slide deck, I will be saying education a lot. Bear with me. Hopefully you won't get sick of me saying it. So why the focus on digital? Well, there was, at the time when we were commissioning these services, there was already a lot of face-to-face services in place that were locally commissioned. What there wasn't as much was nationally available digital courses, and particularly there was a lack of evidence of the success rate of digital services at the time. So on the right, as you'll see, we had, and as I've mentioned, there was 7 in 10 people are offered structured education according to the National Diabetes Audit. There's typically a 3 to 6 month wait for face-to-face services, and then the recorded uptake was 7 to 10% out of those 70% who were offered. There was also massive variation in the commissioning of structured education across localities, particularly in relation to digital, as I said, because there was limited evidence of success of those services at the time. So given those figures on the right, we felt that it was really important to reduce variation in the availability. We were able to provide quality evidence-based services. So the services that we have delivered and commissioned are based on evaluated successful trials of these services that are proven to have benefit to patient outcomes. But also because digital services can overcome some of the barriers to attending face-to-face services, which have been identified by people with diabetes. So there was 2 main elements of research that we have used in this presentation. One is of an evidence review suggesting various barriers to attendance of structured education, and another one which was similarly barriers to attendance, but was conducted with people living with diabetes who didn't take up the offer to structured education. So we have combined those results and summarised them in the next slide for us to talk this through. What I do just want to emphasize here is that we're not in any way suggesting that one offer and one service is better than another. We are very much suggesting that we need to offer patient choice. So we know that digital comes with its own limitations and barriers, but what we are doing is we are providing an understanding of how digital services can overcome some of the barriers that people find attending face-to-face. So it's definitely not that we suggest that there's one service is better than the other. It needs to be about having complementary services so that then when you have a conversation with someone living with diabetes, so just on that, I'm just going to quickly go through some of the barriers that were identified through those 2 pieces of research that I mentioned. So the first barrier that was mentioned was perceived self-efficacy. So this is where people living with diabetes feel that they have felt that they knew what they needed to know, they felt that they were managing adequately, and that they didn't need any other support to be able to manage their diabetes. This is absolutely great to hear if that is the case. But what we have found through the delivery of our digital service solutions is that feedback from people living with diabetes for a long time have actually said they thought that they knew everything that there was to know until they went into the programme and started to learn even more about it. There is also ongoing access to tools and education, which helps manage and maintain that self-management. So even if there isn't a knowledge gap, there is still that opportunity to continue that engagement with self-management through using tools and tips that are on the programs. The next one was low prioritization. So this issue was particularly found for people who were living with multiple morbidities. And they stated that diabetes just felt like one more thing, and that it was not necessarily the thing that they prioritized if there was other more concerning issues for them at the time. So where this may be the case, digital service solutions are accessible at any time for when someone is ready to engage with their diabetes self-management. And often diabetes self-management will support with the management of other conditions as well. So there is a conversation to be had about where diabetes is prioritized within different condition management. But also the bite-sized content can also support engagement for people. So because it means that they can manage the content around other priorities. Another barrier that was raised was limited knowledge about structured education. So this one in particular, I think, is something that can be influenced by referrers. So in particular, the research that was completed with people living with diabetes who didn't take up the offer, they did say that they could have been influenced to attend if referrers had been more positive about structured education, if they'd been made it clear that it was an essential part of their care and just not just a nice to do, and if they'd understood a bit more about what the point of structured education was. So I think this is a really key area that for healthcare professionals it is something that you could actively be able to support someone with engaging with education. Another element of the digital side of things in addressing this barrier is that actually it's a really quick registration. It takes 2 minutes. And so an easy access to a service just allows someone to give it a go. And if it's then not for them, that's fine. But having something that means that it's not a major commitment up front allows someone to test it out, give it a try, and then hopefully by getting their foot in the door, it will then encourage them to continue that learning. The final issue was practical barriers. So the research highlighted in particular transportation and time, taking time off work, for example. And so the issue here was very much that services weren't working around other commitments. And also there was accessibility issues, for example, going to a venue that wasn't accessible for certain people. Where the digital services solutions can support here is that it's self-led, it's online, you can learn from home, it's available on web browsers, it's available on your mobile phone, on desktop, on laptops, etc. So it does mean that there is no physical access requirements or need for transportation or any of those issues around it. It's also developed to be accessible, so they meet the highest accessibility standards for online services. So again, it means that there isn't that accessibility issue from these services. So with that overview of sort of the importance of structured education and how digital might support engagement and addressing some of the barriers to attendance, I'm now going to move on to discussing the national offers that are available. So, is that click through? Yes. So the first one that we have to discuss today is the Healthy Living programme. So this is Healthy Living for people with type 2 diabetes. It's a free online service and it's there to support people to reduce the risk of complications. This is an example of one of our social media ads on this page. The Healthy Living Programme has a really strong evidence base. It was based on a randomised control trial by University College London, and it did show there was modest but significant reductions in glycemic control over 12 months when using the programme, and also a reduction in diabetes-related distress for those who were most recently diagnosed. So on the right is an example of what the dashboard looks like on a mobile screen. We've actually now got over 45,000 users registered to date, and we are conducting an independent evaluation of our real-world implementation of the Healthy Living Programme to see if we achieve the same types of health outcomes in the real-world setting as the trial did. So we were expecting those evaluation results in Q4, so very shortly, to see what to see whether we have managed to achieve the same benefits as was seen in the trial. There are various benefits from this programme, both for people living with diabetes and for healthcare systems. So because it is self-directed, it does mean that it is completed at a time and pace that suits users. And also because it's web-based, as I said, it addresses some of those access issues that were mentioned for the face-to-face services. And for healthcare systems, referrals into the programme support QOF achievement where it is an appropriate referral. So that is, if someone is referred within 9 months of diagnosis, it can be coded for QOF. We then have as well that there is no capacity limits for the service, meaning that it can be made available to on a population health level. We have had areas where they have reached out to their whole ICS level population of people living with diabetes. Full resources available, which are linked at the end of this presentation. And then just benefits that we see are benefits to both people living with diabetes and for healthcare systems are that it's free to access. It's a quality service, so it has gone through Kismet and ORCA accreditations. It is evidence-based, as I mentioned, with reductions in HbA1c for people who have used the programme. It's available 24 hours a day to answer common questions. So another outcome actually of the evaluation was that it did prove to reduce healthcare utilisation because there was quick and easy access to some of the common questions that people needed answers to. So it meant that they didn't make an appointment just for certain questions that they needed solutions to. We also find that it is important and a useful option for ongoing management. So as I mentioned before, we are definitely not advocating digital over any other services. It's about patient choice, but it is also a complementary service in addition to face-to-face. So we also don't see that it has to be one or the other. Often face-to-face services are helpful for opportunities for some peer support and opportunities to learn in a short period of time information that will provide a really good grounding for self-management. But then you find that as life goes on, you may need refreshers, and so having the access to the digital service, which is the same messages, will mean that you have that easy access to be able to refresh your knowledge as and when needed. So we do see it as a not either or, but it's an option to be complementary to each other. This is just a short snippet of a case study from one of our users of the Healthy Living Programme. So Janita used the programme from early 2020, and she once she'd used the programme, she found that she had the confidence to better self-manage. So she also sought some support from other services. So joining an exercise class and a weight loss programme, and has managed to lose 9 stone. one of the things that she said in her longer case study was that she was able to go on holiday for the first time with her son, and her family said this was the best gift that she could have given to them, that she can spend more time with them. So yeah, I just wanted to make sure that you weren't just hearing from me the benefits of this service, but also of people who are actually using the programme. And we've got loads of examples of great feedback in this type of with this type of benefit on health outcomes, and it's lovely to see we've got lots of thumbs up there. So yeah, it's great news. So we've got some other user feedback here as well. Similarly, there was things about improved health outcomes like weight loss or understanding information, but also more broadly around the benefits that are less tangible but still really important, about feeling more confident and just appreciating having trusted advice when you are newly diagnosed, and you know, having somewhere to go to feel reassured and feel confident, so that confident to get the information that you need to be able to self-manage. So less tangible, but also still really beneficial, and can have a really important impact on the way that people then carry on managing their diabetes. So just a few really nice examples there about other feedback from service users. So in terms of how to refer to the programme, we have three main routes that we use for referrals into the programme. So there's the option for self-referral. The link is there, and this means that there's options for creating opportunities for direct communications to reach people with type 2 diabetes. So we've done some national campaigns, but there is also various communication resources such as webpage banners, other social media campaign resources, letters and leaflets to provide to patients. So lots of opportunities to provide the information about the programme for someone to self-refer. And as I mentioned, it's a 2-minute form to register and start looking at the programme. We do have a direct referral option from GP practices. So the form is embedded on GP systems, and there is the link there to where it can be sent. And when that happens, you need the consent from the patient to send the referral form, but then the programme will directly contact the person to finish their registration. So they'll create an account for the person and then start engaging with them to join the programme. And then there is a GP practice bulk referral option. So we have referral letters and text message content which are available from our team. Again, further down in the presentation, our contacts are there. What that entails is being able to send referral letters or text messages to the whole practice register who would be eligible for the programme, and we've seen some really good results from that, and I will actually be going further into that into the next slide. But both the direct referral route and the bulk referral route activity does support QoF achievement. So all of that activity can be coded as a referral to structured education, and as I said, anyone on the register who then meets that criteria of diagnosis within 9 months will support QoF achievement. So we have a good example here of an implementation process where they use bulk text messages. So the ICB was Bedfordshire, Luton and Milton Keynes. They did a search of all of their practice registers. They identified eligible people, and then they sent text messages to everyone. As a result of that, 10% of their population across the ICB registered within 6 weeks, which is really, really successful in these types of campaigns. And for the cost of that, it was a relatively cheap cost to have that population health approach. It cost 2 pence per text, and they were sent to 47,000 people, so £940 to be able to offer a service to everyone across their ICB, which is really, really low cost. In this instance, because they were helping us develop the process for the national team to check whether it was successful or not, they did pay a practice incentive. Even with that, the cost per registered user was £4.70, which again is really cheap for this type of intervention. What they have said is that from their lessons, it was to engage with GP practices and make it easy. So they did it. They built the clinical search, they provided the copy, and they provided all of the implementation. So it was done once instead of each practice having to do their own thing. They did find that incentives encourage activity but aren't necessary. They are actually going to repeat this activity but without the incentives now that they've done that first approach. And the reason why that incentives isn't necessarily necessary is because of the QOF achievement. So because there is money potentially coming in from that QOF achievement, that can act as the incentive in itself. And they found that there was actually really limited requirement on staff time and upfront costs, which again is why they feel that they don't need to incentivize again. So we feel like this is a really good option for any areas that are able to do population health bulk referrals, because it maximizes the time and benefit to patients. So really, really happy to share any information on that if any areas are interested in doing that. So please do get in touch if you'd like further information on that. So that's the offer for people with type 2. This is our offer for people with type 1. So this is my type 1 diabetes. Similarly to Healthy Living, we have a screenshot on the right to see what this looks like on a mobile phone, but it also has very similar format, but just different content. So this one is aimed at people with type 1. It includes tailored advice and educational resources. Both services have been created by NHS experts and in association with people with diabetes. So relevant clinicians such as dietitians, GPs, practice nurses, etc., have been involved in the content creation for both. Again, the aim for this one, like Healthy Living, is that aims to support users to gain an understanding of their condition and increase their confidence. It's web-based and optimized for use with multiple devices. It's free to healthcare systems and to the participant, and it's being used by over 9,000 people to date. For this service, there isn't the direct GP practice referral option, but there is self-referral. So again, there is resources that you can sign up for that the national team pay for, such as leaflets and posters, which will support the self-referral to the programme. You can therefore, as with Healthy Living, use direct-to-patient communications to encourage use of this service. Again, we've got some user feedback, which outlines again that sort of self-efficacy side of things, where people may feel that they know what they needed to know, but they've been living with diabetes for a long time and they've used these programs and have found that there has been really useful content for them. They've been able to pick and choose what they needed to know, and they've found it really beneficial. Lots of feedback from both services have said around, we wish that we'd known about this when we were diagnosed, we wish we'd had this opportunity. So it shows really the importance of making sure that people are aware of the services available at diagnosis, and again through the years, because we can't assume that just because someone's been living with diabetes for a long time that they feel well educated and confident to manage their own diabetes. So it just really hammers home the importance of sharing these options all the way through the pathway. So I'm just going to round up with some key messages. I really hope that I have I've helped increase the understanding of how important structured education programs are in improving health outcomes, reducing patient distress, and in the long term, it will also reduce time and costs for the NHS by increasing people's self-efficacy and encouraging confidence to self-manage. Referrers do really have an influence on willingness to take up structured education, and the key ways that you can do this is being positive and enthusiastic about the benefits of education, and also supporting people living with diabetes, that it is an essential part of their diabetes management. I would like to encourage you to make best use of locally or nationally commissioned services, either face-to-face or online. And just a reminder around that online services can provide patient choice and address some of the barriers to attendance, along with supporting that continuous self-management alongside face-to-face services. So it's very much about understanding what you have available in your local area, having the conversations with patients and offering the service that meets their needs. I mentioned that we've got lots of resources. I won't go through this slide now but there's lots of links that will be shared with this presentation. We have various patient-facing resources. You can register for printed resources, so we pay for them. It's completely free to you, and we will distribute them if you provide your details. And also, if you wanted to hear more from the national team about the different services that we deliver, then you can sign up to our regular news bulletin through that link as well. And on that, I think I've done that to time. We've got a bit of time to do some questions.
Absolutely. So thank you very much, Helen, for running us through that presentation. So any questions you have, we've got some in the Q&A already, but anything you can think of, please just pop them in the Q&A, and if we've got time, we'll get to them. But just to confirm that we will be emailing you certificates of attendance, the PDF of the presentation, and an implementation pack with all the links that you need. But if you don't receive this email, please do contact us at info@cdep.org.uk, that we will be able to support you. So you will get all this information. I'm just going to stop sharing the screen so that we can have a good conversation. So Helen, there's some interesting questions here. So I'm going to launch straight in, if that's okay. First question is around languages, and what languages are available, because we've got a diverse population in the UK.
Absolutely. So in the My Type 1 education service, there is translated content in 11 languages, and you'll have to forgive me, I can't remember the 11 languages off the top of my head, but we can share that information around after the call. I'm happy to take that away, but there is definitely resources in multiple different languages. For the Healthy Living programme, at the moment, it isn't translated. We are looking at options to do that, but currently the option that we use is the same as the NHS.uk approach, which is to support people to understand the way to translate online web pages. So we do acknowledge that there are some limitations with that route of translation. However, we have followed the same process as other national services on that. We are, though, looking to be able to provide them in different languages in the future.
Fabulous. And then there's a specific question about healthy living. Is it available throughout the UK, or is there specific sort of limitations?
So Healthy Living is available in England only. We do see that we have had some people manage to get access from certain areas in Wales and Scotland, but in terms of sort of the commissioning, it is England only, and it's because of that commissioning arrangement, we're only able to feed back directly to GP practices in England as well, because of our information governance and our permissions around sharing information and that. So hopefully that covers that question.
No, thank you. And then just thinking of Janita, who's lost so much weight, can people do they just have to do the healthy living, or if they've done sort of a weight program, does that exclude them? Is there sort of one bite of the apple, as it were?
No, so it absolutely doesn't. I think, as I was mentioning around the complementary services of just structured education, it's not actually just those that are complementary, it is other services as well. So, for example, the weight management service is largely focused on weight management and weight loss, whereas the content on healthy living is much broader. It's about the management of the condition. So they are complementary. There are no eligibility criteria for healthy living other than being 18 plus, which means that you could be attending both at the same time, whereas for the weight management programs, you have to meet certain eligibility criteria in terms of BMI. So again, that they can be complementary, or it might be that one or the other needs to be prioritized. But with healthy living, for example, there's much more content than just about weight management. It talks about reduction of complications, how to look after your eyes, your feet, your heart, and also talks about getting active, how to get the best out of the NHS, so how to work well with your healthcare team, the types of care that you should expect, so that people know what tests and reviews that they should be having. So it supports someone more broadly with their diabetes. So definitely not a one shot and you're done. It's complementary and quite holistic as well.
Fabulous. So leading on to that, we've got a question about people sort of, for example, the older population living in care homes. Might they still be able to access this kind of healthy living or My Type 1?
Absolutely. So we do know that there are some issues with access in terms of digital literacy, and also digital access. So some people obviously don't necessarily have their access to their own laptops or their own phones, but we are working with various inclusion teams to find ways to encourage people to use the program on different services. So working with libraries or help supporting people with access to technology to be able to access the programs. So in the instance of care homes, it would depend on whether there is the opportunity in care homes to get access to something that's online. But if there is something that one of the attendees wants to discuss on that, please do get in touch. I'm happy to talk through ways that we can support that.
Great. And sort of leading on to that as well, so could a sort of a care worker or a healthcare professional register and then sort of do it with maybe somebody who is maybe unable to attend or access because of digital or literacy or something like that? Is that a way we could use this?
Absolutely. So both services allow for healthcare professional and carer access to the services. So they will be able to access the information and support the individual. So either, like you say, they could support someone to access the service for the individual to go through it, or they can access it on their behalf. For example, if they are responsible for meals or support, that they can then learn the information themselves to be able to actively support that individual through improving their own knowledge. So absolutely, access for carers, healthcare providers, anyone can join the service.
Great. And then what about people with other types of diabetes or maybe even pre-diabetes? Can they access these?
So for pre-diabetes, we don't recommend this service. We recommend the National Diabetes Prevention Programme. So this has been a well-established programme for the last 5-6 years, probably slightly longer. This service is the preferred option for prevention. It is a structured service. It's available digitally and in person, and it's a 9-month structured programme. So for people with pre-diabetes, we don't recommend healthy living. We recommend the prevention programme instead.
Great. And other types of diabetes, is it just you have to have a diagnosis of type 1 or type 2 to do either of those? If you've got MODY or something different, you'd recommend them doing something else or seeking some local support?
That's right. So for these two services, it does need to be the diagnosis of type 1 or type 2 and 18 plus. There are other services. So, for example, we commission a national service called DigiBeat for children and young people with type 1. So I think we're going to potentially be doing a different group of sessions of webinars on that group. So there is another national service for that group, and we are also looking at developing content for example, gestational diabetes. But at the moment, we just have the young people with type 1 and then 18 plus type 1 and type 2. So any other types of diabetes, you would need to be looking at what is commissioned locally to support those individuals.
There've been a few questions coming through just to confirm what you said about compensation or sort of supporting incentives for the practices to refer. Just remind us what the guidelines are there.
Apologies, could you just repeat that question? Sorry.
So it's about compensation for the practices to refer. Is there any structure in there?
Okay, yes, thank you. Sorry. So with the compensation to practices, there is not going to be implementation funding from the national team to support that. The best practice case study was supported by the national team to be able to understand the whether it was a benefit and whether it could be rolled out. So that was an individual case. So from the national perspective, there wouldn't be any more funding for implementation book referrals, but what we have learned from the sites that have done it is that they don't feel that there would be a need to incentivize practices for that activity because they will be recompensated for their time, most likely through QOF achievement instead.
Great. So they've got the QOF that they can tick that box for and then get that. Great. The apps, both apps, are they interactive? So that they would, when you're going through the content, that they would remind you about maybe checking your HbA1c or helping people sort of manage their diabetes as well as just learn information along the way, because we all know behavior change and getting the support at the right time is so hard.
Yeah, that's right. So there are multiple reminders, and there's also tools and trackers within both services to be able to actually track those measurements and health outcomes, which again encourages people to engage with those data. So we do throughout the programs encourage engagement with checking levels and monitoring levels and actually tracking those, and then being able to have conversations with your healthcare professional about any changes in that.
Been a question about people having insight into what is in the program, like a snapshot. Would you encourage people to, are they available, or would you encourage people to sort of register as a healthcare professional and give it a go?
I'd be really happy for anyone on the call to just register for the program and give it a go. As I said, for Healthy Living, it's a 2-minute registration process. For My Way, it's actually a lot of open content, so you don't even need to sign in for those. So probably the best way to get a feel for the different services is to go in and have a look at them. But we are sending out implementation packs for the Healthy Living service, and in that there are some summaries of what it delivers in terms of the types of content that is available and the tools and trackers. So there will be options for you to understand better what the content looks like from that implementation pack if you don't want to have a look. Oh, and someone's just registered, so great.
Yeah, it said it was quick and easy. Fantastic. Well done. Great job. And I think that sort of, I'm looking at the time, draws us nicely to a close. There have been a few questions about when you're going to get certificates and all the information. We will be emailing that out to you. We will be using the emails that you've registered with. So if you would prefer it to go to a different email, please do email us at CDEP. It's info at CDEP.org.uk, and we will send you through that. If you don't receive anything from us in the next 1 to 2 weeks, please do nudge us as well, but you should receive it. Just sometimes emails go astray, so hopefully that doesn't happen. But thank you, Helen, and thank you for everyone for attending. We've had a great session. Please do give us your feedback. You'll see that we'll be requesting some feedback just to know how we could do this differently, what we should do next. So please feel free to give us your thoughts, share us your thoughts. But thank you very much for your time, and have a great rest of your day.